All right, thank you and welcome everybody. I'll just start sharing my screen so you can see the presentation.
Yes, please.
Hopefully you've got that in full view.
Yes, thank you.
All right, so we'll begin. I'll go back to the, it's frozen, perfect timing. Let me just get it back up and running, excuse me a minute. And screen share again. And okay, thank you. So
wonderful,
yes.
We can see it.
Yeah, excellent. So the topic is a little bit about iron deficiency anemia, which is something that's extremely common. And particularly, I'm going to focus more on patients who have recurring iron deficiency anemia. It's something that we as gastroenterologists refer to as obscure GI bleeding. So, but the borders between iron deficiency anemia and recurring iron deficiency anemia sometimes are quite blurred. So we'll talk about it, and I think hopefully we'll get some key learning objectives and points through today. So iron deficiency anemia is very common. It's particularly common in our society and in the West. And it's something that I think primary practice as well as specialist practice has to deal with on a very regular basis. So here's just a little diagram and schematic about sort of broad causes of iron deficiency anemia. If you come to the top left, you see mass lesions, and we're essentially looking at things like cancers and large polyps, inflammatory lesions. Again, the border on this is a bit blurred sometimes, whether things like reflux esophagitis and such can cause iron deficiency anemia, because a single episode of bleeding from, say, gastric ulcer is very different to a recurring iron deficiency. But nonetheless, we need to consider these things, particularly celiac in young women. Infectious causes are very unlikely in our society. I think one that's often overlooked is long-distance runners. So, excuse me, people that are triathletes and marathon runners and so forth often have iron deficiency. And one thing that's not as appreciated as much as it should be is vascular lesions. And this, you'll see, according to data, is actually one of the most common causes. So here is a paper that was produced some 30 years ago in the New England Journal of Medicine. And this paper basically showed 100 patients who had iron deficiency anemia. And you see 26 of them had a positive finding at colonoscopy, and 37 had a positive finding at gastroscopy for a cause of the iron deficiency anemia. So in all, about 2/3 of patients had a positive finding. But what's unusual, and I can't fully understand why, is things have changed. And this is a paper that we published a few years ago, looking at 100 consecutive patients with iron deficiency. And you can see here about 30 patients said gastroscopy had a cause and only 9 at colonoscopy. So under 40% of patients. So that's a significant drop. And partly it's less colon cancers and less peptic ulcer disease and erosive gastritis, as you know, things like Helicobacter are managed. So things are changing, and we're removing some of the more obvious causes of iron deficiency anemia. So we know the paradigm, we all live it, where patients have iron deficiency anemia. No cause is obvious, so they've not got heavy menstrual loss, there's no urological or nasal bleeding, and the typical recommendation is to refer to the gastroenterologist. And the lines can be a little bit blurred. You can see here on the right, if you're an adult, postmenopausal women and men, you're looking for a variety of common causes. Some of the blurred areas are particularly younger women who still have menstruation, and when do we trigger GI investigations in them? And you can see some recommendations such as GI symptoms, family history, and particularly you can see here's highlighted recurring iron deficiency anemia. I won't be talking much about children because that's not my area. So some years ago, now 10 years ago, we published a review on this particular point, and I just want to draw your attention to a couple of the sort of controversial areas, such as premenopausal women, patients who are anemic with a fairly low normal to normal ferritin. And one of the things you'll notice in this data is that essentially, if I can highlight it for you, there is a significant finding rate. You can see up at 37% and 30% here, but it's very uncommon to have really significant. So things like GI cancers are 0 to 3%. So still worth investigating, but you're just not investigating for cancers. So it's important that these peripheral patients still get some GI attention. And the same is for iron deficiency without anemia. Malignancies, again, in at least one study showed 1%, but still significant findings up to, a quarter of patients. So I guess the problem is when you have these patients and they have a gastroscopy and a colonoscopy and you don't find much, what would you do next? Well, particularly if they're recurring patients, they fall under the definition of obscure GI bleeding. We've tried to change the nomenclature on this a few times, but this is the one I prefer. And you can see one of the key is not just intermittent heavy bleeding, melena and such, but positive FABTs or ongoing iron deficiency is actually probably one of the more common groups, and they need to be investigated under this new banner, this new diagnosis. And of course, the absolute fundamental step in these patients is capsule endoscopy. There are some cases with overt bleeding that are very heavy in hospital, which we may decide to go on a separate path, but fundamentally capsule endoscopy is the key intervention or investigation in these patients. Capsule endoscopy has been around for a long time, and early studies showed that it was clearly better than enteroscopy, clearly better for significant findings and total findings, clearly better than radiography. It's clearly better depending on whether the problem is either a vascular lesion, inflammatory lesions, or even neoplastic lesions. So it really changed the world. It blew everybody apart because before we were really hamstrung on how to investigate. And capsule endoscopy findings are important because it doesn't always mean we have to send the patient to surgery. We have endoscopic options. We may opt for something fairly conservative. If a patient has a small vascular lesion in the small bowel that oozes, we can just ignore that and manage the patient with some iron replacement. Or if you have a disease such as Crohn's disease, you can commence medical therapy. So I'm just going to show you some videos. This is often the best part of the presentation in the videos. This first video, you'll see someone swallowing the capsule, and you'll see the capsule go through the esophagus. So it's through the back of the tongue here, down the esophagus, through the junction and into the stomach. And it's very clear, and you can see some very nice views of what is quite normal upper GI anatomy with a little bit of an erosion that you saw just here. The next video is quite interesting, is in a patient that's had some recent treatment for bleeding. Sorry, I'll just pause that there. Go to this one. So we're in the pylorus, the antrum of the stomach, and it'll pop now into the small bowel. You can see it's changed the lining. It's a bit like a furry appearance that's typical small bowel. And you can see a metallic clip that's been placed endoscopically. And you can see there's another polyp. And this patient actually had a polyposis syndrome and was bleeding from that. Another video, we're in the small bowel, as you can see, and as the capsule's passing through the small bowel, you'll see it suddenly pop into the colon. And again, the mucosa changes, preparation's not as good, and now we can identify the key landmarks, and we can view a lot of the different areas of the gut. On the right, you can see the name here is a bit different, PILCAM Crohn's, and I'll talk to you a little bit more about that in a minute. But just watch this video, it's quite interesting. And that is a patient who's passed the capsule, it's gone into the bathroom and they've picked it up with their hands. And so we are now often able to get total views of the gut right from the mouth right through to the anus. And that's a little bit of another shift in the way we do things. And again, I'll talk to you more about that in a minute. So let's look at some pathology. Again, using the PillCam Crohn's type, which is a new type. You can see in the small bowel, looking around, and you can see there on the right-hand side, a little vascular lesion. And this is simply the most common finding at patients who have iron deficiency anemia these days. And vascular lesions have been underdiagnosed, but are becoming more and more relevant. And here you can see in the same patient, actually, the capsule's passed into the colon. You can see a very large vascular lesion, which is in the right colon, which ironically was missed by colonoscopy. And another video here. This is a patient, again, who you can see the capsules passing through the small bowel, and something appears in your view. And what that is, in fact, is a large pedunculated polyp. Again, in a patient that's got polyposis syndrome. And we now know that the patient's losing blood from this lesion, and we can proceed to appropriate intervention. So Capsule has many benefits, and I'll run through some of them for you. First of all, we saw that it's clearly the best diagnostic tool. But in patients who are bleeding, getting in early is important, because getting in early actually improves your diagnostic yield. The sooner you send the patient for referral, the more likely it is we'll get them a diagnosis. The other important thing about Capsule is that if the capsule endoscopy is negative, studies going out to 2 and 3 years follow-up have shown that the chances patients will bleed again are far less, indicating that it can actually give you a good prognosis for the patient and sort of give them some confidence that, you know, everything's okay and they should be fine, with less than 10% having problems in the future. So it's a really good triage or management stratification tool. But I guess we're doing a good job, but can we do better? And some of the things I think we can do better with is, can we predict patients, if you like, on a priority basis to have endoscopic intervention when they do have iron deficiency? And can we change the whole algorithm and the protocol so that currently patients have their endoscopy and colonoscopy followed by a capsule? And maybe we need to revisit that when you consider the literature. One of these things is called the IDIOM score. And essentially the IDIOM score is just logic. If you have someone with iron deficiency anemia who's fairly young, is only mildly anemic and is asymptomatic, we know from studies that the chances of having a cancer are very low. And this allows us to prioritize patients to procedures, how soon, and again, you can move into suggesting that maybe there's alternative ways we can investigate them. Another thing that we did, and this is a project that Prof Riordan and I did together, that you can select out patients who are likely to benefit, say, from a capsule endoscopy. And in fact, what we found is if a patient had any form of anticoagulation, aspirin, Plavix, Noax, like Eliquis or warfarin, it didn't really matter. They were all pretty much the same. Their diagnostic rate for significant, what we call P2 lesions in the small bowel at a capsule endoscope, were much higher. I was always under the impression that, in fact, these patients were likely to be bleeding from nothing or very little because of their anticoagulation. But it was to my surprise that it was quite the opposite. And it suggests a link, if you like, between these medications, the comorbidities, the reasons why they're taking the medication, and the creation of angioectasia type lesions, which is something that we haven't really had good clarification on. But there is a new capsule where you saw a little bit before, and it's quite interesting in that it's got a camera at either end of the capsule. It's got a longer battery life. It's got intelligent technology, so it doesn't waste images, what we call adaptive frame rate. And in many cases, we're using a prokinetic agent similar to motilium, procalipride, to get total gut views. And you saw a case where the patient was able to swallow the capsule and pass it into the toilet well within that 15-hour mark. Now, that's a game changer, because for the first time ever, we've had a capsule that can go all the way through and actually view the entire gut. And that's what it looks like there. You can see the cameras on either end. It's a little bit bigger than the standard capsule. And, you know, we can use it really effectively to get a look at the entire gut, which again is something we haven't been able to do. And ironically, I'll tell you a bit of history. When PillCam first came out by given imaging, they actually called it the M2A capsule, which is mouth to anus, even though they weren't really able to achieve it. And ironically, 20 years later, they may have to rename it that, because we're able to get this capsule all the way through to the anus. So one of the very interesting things that I've been doing recently, which again is something to explore for a possible change in the way we do things. We're doing a study where we're collecting patients who are low IDIOM patients. So they're unlikely to have a malignancy. And we thought it would be an appropriate thing to study these patients particularly. And then we did this capsule, this new double-ended Crohn's capsule, with our prokinetic to get it through. And almost always we'll get total gut views. And in our initial data, the ability of the capsule to diagnose the cause for the iron deficiency compared to our standard and traditional bidirectional endoscopy. So we did the capsule followed by gastroscopy, colonoscopy the next day. What we found is the diagnostic yield was almost 4 times higher. Because as I said before, the world is changing. We're not seeing cancers as much. You know, the National Bowel Cancer Program is finding these early. People are getting their colonoscopies and surveillance. You've got the situation where, you know, Helicobacter is eradicated and so forth. And so what's left behind really are these vascular lesions, which actually are detected a lot easier using a capsule. And more importantly, what was it, for us at least, important as part of the study, and we're almost finished the recruitment now, is that missed lesions are very, very, very uncommon. And that's by capsule. In fact, missed lesions are more likely with a colonoscopy. So I've shown you the data where iron deficiency anemia these days doesn't yield a great diagnosis in most patients. In fact, at least half the patients, we just don't have an answer. And that even when we get total gut views with this fantastic new capsule, the diagnostic yield still sits at about 40%. So really, most of our patients don't have a diagnosis. And I think that's the very first thing I tell all my patients who have iron deficiency anemia is that, guys, we'll go looking and we'll exclude pathology, but we may not ever find out why. But I also need to point out to you this particular study. So this is a study done some years ago in Germany where patients with bleeding came into hospital. And again, there was this obscure bleeders. They all had a capsule endoscope followed by a complete surgical evaluation of their gut, what we call an IOE, intraoperative enteroscopy. So this is a surgeon who cuts open the patient. You look through the bowel with an endoscope while the surgeon's on the external part of the bowel, and you get a complete evaluation. And they found that there was very little the capsule couldn't find. And they delivered the definitive treatment. If it was endoscopic treatment, if it was surgical therapy, they fixed these patients. But here's the problem. A year later, they published that 25% of these patients who had surgery, the most definitive possible intervention, still had bleeding. And about 20% of them, 19% to be exact, had further intervention and blood transfusions. So I guess the key message for everybody today is that if you have a patient with recurrent iron deficiency, we need to look, but most of the time they'll continue and we just won't know what the cause is. But there is value if you don't find a cause until looking again. And there have been many studies, whether it's with enteroscopy, with capsule, with special endoscopies, whatever your data is, there's always missed lesions. There's always a reason to look again. Here's a nice example of a patient that had a very large angioectasia on the left, sitting in between stomach folds that was missed the first time. and was actively bleeding when we went down and had a look at it. And this is one of the studies we did with our enteroscopy data, showing again there was 25% of patients had a lesion found that was initially missed. And so it's important, if you're concerned about the patient, that you keep on looking. And again, capsule data showing that a second capsule has a good diagnostic yield if the first one was negative. And this Korean study showed that 2 capsules is better than 1. So we just may need to continue looking if we're concerned. In fact, I had a patient exactly in this circumstance today. We had another repeat examination and found a vascular lesion and ablated it, and we got a great result for her despite 2-3 years of multiple procedures. So iron deficiency anemia, many will never have a diagnosis. I think our objectives, particularly my objective, is to make sure the patient doesn't have any malignant or pre-malignant sinister pathology. I think also it's nice to know what you're dealing with, even if it's a vascular lesion, because then you can guide therapy, educate the patient and explain it. But I think we need further research, because I think we can do better than what we're doing. I think there's too many people having unnecessary procedures, and we may be able to streamline what we do to actually something simple like an outpatient capsule procedure, and then if we need to, a targeted procedure such as a colonoscopy or an endoscopy or similar. Thank you very much for your attention.
We don't appear to have any questions at the moment. We have a couple of minutes left. If anyone has a question, could you put it into the Q&A box now for Dr. Kaffes?
Should I stop sharing my screen at this point?
You can stop sharing the screen, and we'll just wait for a moment and see if we have any further questions come through. Do you have any other comments?
Yeah, look, I think it's actually a bit it's a bit frustrating for the patients when I tell them that there's a good chance we won't find out a cause, and particularly if it perseveres and people are worried that, you know, it's hard to explain. Look, we can look and keep looking. We just won't necessarily get there. Okay, we've got a question. Can medications such as PPI inhibit iron absorption? Yes, because iron absorption is linked to acid, and often you'll have iron now, as you know, is linked to vitamin C in ferrograd C to improve absorption. But these are marginal changes. You know, one of the key questions I have from people is, what about Helicobacter? Does Helicobacter cause iron deficiency? We had a look at this a few years ago in my early days as a consultant with a colleague at Concord. And what we found is that Helicobacter is a stressor. It actually affects your ability to absorb, and it may increase your chances to lose iron, but it's very, very minor. And it shouldn't actually be a cause of iron deficiency unless it's giving you a complication such as severe erosive disease or an ulcer. How operator dependent is a capsule endoscopy? And is AI available? So the capsule is like anything operator dependent, but it shouldn't be that operator dependent. It's pretty standard, it's pretty routine. I think that it has its limitations as a technology, but it's not really something that would be so much operator dependent. Needless to say, you know, experience counts. So someone who's done a lot of this is usually good at identifying, you know, relevant pathology. Otherwise, some people who are junior will pick up things that don't matter, and you're in this sort of rat race to prove nothing is nothing. And there is AI being developed for it, definitely, which would be good, that you can run AI over it, and you'll be able to sort of get someone to do the work for you, which is not always a bad thing. The cost of PillCam, a pill camera is covered by Medicare, but it was absolutely hammered. It was smashed during the last review, and it was culled by about 40%, which is never happened before in the history of Medicare, as far as we know. And so a lot of people are charging a small additional fee to cover their costs. But generally speaking, it's pretty much covered by Medicare as an outpatient procedure. Can you see eosinophilic esophagitis on PillCam? I've never seen it. I've never diagnosed it that way. I'd be a bit worried that the capsule would get stuck in eosinophilic esophagitis because, as you know, it narrows and spasms and it might get a bit of hold up. But I guess you could see some of the changes that would be suspicious, but EOE is not something that causes iron deficiency. So I think it would have to be a very incidental or asymptomatic situation.
Well, thank you, Dr. Kaffes. That's great. We have no more questions. So thank you for your presentation tonight.
Thank you.
Our next speaker is Dr. Penelope De Lacavalerie, and she is a colorectal surgeon and will be speaking on the bottom line, an update on anal dysplasia and cancer.
Good evening, everybody. Thank you for having me and for inviting me to finally have some sort of interaction with you, my colleagues, after such a difficult year last year, not being able to really do much in person. I'm just going to share my my video, if I can. Just open up. Okay. Okay. And share view, sorry, a little bit slow. Okay. Can you see the?
We just have to put it in presentation view.
Yep, go for it.
Great, thank you.
Can everybody see? I'm guessing yes.
Yes, we can.
Okay. So mainly when I got asked to see what I would like to discuss about with gut health, I knew that there was a update being done by Professor Newstead only a couple of years ago on the new guidelines of in colorectal cancer and when to do follow-up surveillance and take care of polypectomies and all that. So I thought that instead of, going through the same, which most of you, of course, already know, I thought that there was just to share some exciting upcoming changes when it comes to anal cancer, which is not as common, as you all know, cancer as you will compare colorectal cancer, which is the second most common cause of cancer in Australia. But it is particularly more common in predisposed populations that we may or may not think of when we see them. And in particular, you as GPs will see them as a first port of call. So today we're just going to talk about a case. And then after talking about the case, we will go through some updates on epidemiology. And towards the end, I hope that you will be able to decide and see what patients need to be referred to us. I want to acknowledge that some of the slides have been given to me by Professor Richard Hillman, which I had trained on to do high resolution anoscopies at St. Vincent's. And as he is the guru of this, or the only center in Sydney really that does this regularly. And I'm just joining the team. So I thought that I would just talk about a recent case who a patient of mine, female, 54, who was a previous, aircraft hostess. She came to her GP basically because she had some non-specific symptoms of lethargy, low energy. She's a marathonist, does a lot of kayaking, and she felt that her energy wasn't really the right. She thought it would be related to premenopausal symptoms, but the GP, rightly so, did an FOBT and it was positive. So she was referred to me for colonoscopy. On further questioning, she had a couple of episodes of PR bleeding in the last few months, and she always thought that it was just related to her hemorrhoids. On examination, she was quite pale. Her abdomen didn't arise any abnormalities. Her groins didn't have any lymphadenopathy. Her PR&D shown was palpable a 2 centimeter lesion at 1 centimeter from the anal verge. This was quite mobile. It was not tender, and there was a small amount of blood. So of course, the next step was to do a gastroscopy and colonoscopy, because she also had some symptoms of reflux, non-coincidental with this. At the top, you can see her gastroscopy, which was pretty much normal. And at the bottom, you can see her colonoscopy. You probably can see it properly, but this is the lesion there. It's quite low, so it was quite difficult to actually see on proper colonoscopy. And of note, really, any anal lesions should either do a retroflexion and also do a high resolution anoscopy, because these are the ones that you would be able to see. This at the bottom of it is where I excised the lesion with a margin for pathology. Okay, so the anal lesion then was reported as an HPV-associated SCC. The type of HPV related with this is to be done as it wasn't done before we did the actual excision. As you can see here, there is very changes in the crypts, which look like an SCC, and it's all the way down present, very close to the diathermid. So that is a bit of a concern, because was it probably properly excised? There was certainly nothing else but internal anal sphincter, so anything else would have been much more morbid to excise. Therefore, we discussed it on the MDT. The decision of definitive chemoradiation was done and was sent to see the oncologist and the radiation oncologist. And in about, when she finishes a chemoradiation, I will surely perform a high resolution anoscopy, which you may or may not be aware of what it is, but it's pretty much basically using, as you can see on this picture here, using a colposcope with an anoscope to see basically the anal canal. Then we use a double dye. We use vinegar, basically, which is basically acetic acid, and Lugol's solution, just to enhance these changes that can be related to dysplasia and carcinoma sometimes. So what is anal cancer, and how often or how prevalent it is in Australia? So it's really a generally rare type of cancer in the general population, with really only 1 to 2 cases per year per 100,000. But it's quite high rating in specific populations, and those are the specific people that we want to make sure that we don't miss and we refer. In Australia, there's about 500 cases a year and 90 deaths related to this. And these deaths are actually usually younger people. The peak of this cancer is between 50 and 60 years old for men. And their deaths are entirely preventable. When you see and compare how the cases of anal cancer have changed from 1980s to 2015, which is when this census was done, we can see that there has been a quadrupled in number for both female and male and together. And this sort of doesn't make sense, because we do know that the highest risk population are gay men, MSM, and HIV positive. And even though there is being a decrease in the HIV positivity, there is still an increase in the anal cancer cases. So why is that? What are the things that in the population that determine that the incidence increases? Well, aging, of course, female gender in particular has now been shown that, in particular in the eastern suburbs of Sydney, we have a higher percentage of HPV-related infections, and therefore genital and anal anatomical proximity increases the HPV cross-site transmission. Sexual behavior, of course, MSM is a higher risk, and immunosuppression, not only from patients with solid organ transplants, but also with chronic immunosuppression, as in inflammatory bowel disease. When we go and have a look at the age-specific comparison between cervical cancer in yellow and anal cancer, both in female in red and male in blue, we can see that the peak of cervical cancer usually happens in the 4th decade, whereas in the anal cancer, it starts to peak more towards the 6th decade. And the risk groups, this is sort of a summary of which are the type of patients that we should keep an eye on and that we may have to consider, have a peek and have a look at doing a PR, or at least inspecting whenever they have very non-specific symptoms as itchiness, small bleeding, thinking that they have hemorrhoids, and making sure that someone has a look and maybe refer if there is in doubt. So we know that the highest risk is HIV post-MSN and also HIV post-non-MSN. HIV post women, actually, although are increased risk, they are lesser risk than women that have had lower genital tract oncology or cancers, including vulva, cervical, and vaginal. Patients with solid organ transplants, SLE, UC and Crohn's. UC and Crohn's is not as high, of course, but the rest are increasing with time. If you take anything from my presentation tonight, this is the slide that is to remember. This is basically a clinical grading of risk, depending of the risk factors. Anything in red is the highest risk. Anything in orange and yellow is moderate risk, and anything in blue and green is lower risk. Higher than the general population, but still lower risk. So even with patients who are HIV positive, the incidence of vulvar cancer and vaginal cancer and cervical cancer is almost in the same level of those patients that have chronic immunosuppression from the HIV. So things to remember. And then there is a tale of two cancers. How good has it been, the screening process for cervical cancer, and how the incidence is going down and have plateaued over the years. Whereas with anal cancer, really, we haven't done much, which makes us think that really we need to get closer to a screening tool like we have found with colorectal cancer. In order to choose a screening test, we need to make sure that the screening test, as you know, needs to be cost effective, needs to be easy to perform, and gives you the best result to find the most amount of patients with it. So there's been recently lots of research around using HPV genotyping together with a anal pap smear cytology. And as we know, HPV 16 and 18 carries the highest risk of causing anal cancer, but there is also other HPV high risk or HPV high risk other long list that can also be associated with anal cancer. And you may be able to see this on the reports that you get from us. How do we prevent anal cancer? Well, we are trying to change things since the Gardasil and the quadrivalent vaccine is happening, but we will have to wait until that cohort of patients become older to see how that will impact. Stop smoking is very important, as people who smoke have a higher chance of developing anal cancer when they have the other high risks. Sexual intercourse, there has been a lot of taboos around this, and there's a lot of patients that believe that they don't understand why they can have anal cancer when they never had anal intercourse. Most of my talk with them is actually trying to break that taboo and to make them understand that they don't need to feel guilty and they don't need to feel ashamed of it. It's a very, very contagious virus that can spread by just touching hands, skin to skin contact. And even when you use condoms, I tell them that, it doesn't matter, that will protect you from that part of it, but everything else can get infected. And of course, it's important to have condoms for preventing other STIs and HIV. There has also been some recent evidence that suggests that women can spread the HPV from the vaginal region to the anal region because of the wiping traditional way from front to back. So what do we do then with screening? And when we see these patients with either a high risk, HIV positive, older than 35, or women that have had lower genital tract malignancies, or people that have basically a suspicion of a lesion down there, we do HPV genotyping, which is done together with a anal cytology by doing an anal pap. We, of course, examine and do a day exam and a groin exam and abdominal exam. And then depending on those tests, we have different answers to this. It can be negative. It can give you anal squamous cells that are non-significant, which it's not very useful, but basically it could be either, that could be either an LCO or HCO, but they don't want to call it. LCO, which is a low intraepithelial lesion, and a high-grade intraepithelial lesion. We do know that there is regression from an LCO back to normal, and we don't know yet how much of the AIN2s actually can do that too, but it's about 20% what they quote. How do they progress from HCO to carcinoma, and should we be treating all of the HCOs? Is at the moment on the investigation on the biggest anal dysplasia prospective study called the Anchor study, which is based in San Francisco, and is due to finish at the end of next year. And I think that study will actually change a lot the world of anal cancer. So if any of these are present in the cytology, then we do an HRA and we biopsy any areas that need to be biopsy, basically. And depending on that, then we will treat. So what is high resolution anoscopy? So it has come from the development of cervical colposcopy. It's basically using a colposcope. We can able to see sub-millimeter size cancers and changes. It's a bit more technically challenging, that colposcope, because of the anatomy of the anal canal, sorry, and it's very limited availability. It's really only 5 centers in the whole of Australia that does them as regular. One of them is St. Vincent's, but we're trying to make it a bit more available by training more people. This is one of the type of images that you would see in an anoscopy. This is an AIN3 or HCO. You can see how the difference on this lesion here, which is Lugol positive, to this image here that is Lugol's negative, which makes you think that there is a high grade change. And we can see this difference of things that these are all non-palpable tumors, by the way. So basically, so we know that they, even though we need to do them in high risk populations once a year, and that's the current recommendation, it doesn't mean that you're going to be able to palpate any of this. But until the guidelines change, it is what it is. So there's no screening guidelines in Australia at the moment, but at St. Vincent's, we recommend follow-up in any patients that had anal cancer every 3 to 6 months. And we perform a day exam, a groin exam, and an HRA. Once a year, we do an HPV genotyping to make sure that the patient has cleared, because we know that the virus is what drives the changes in the cells, and also an anal cytology. It's just another one. The day was absolutely normal, and this patient had HCO. Is another patient with an SCC, and the quality of the images, as you can see, is very good. This is how we report it, and you may get, or you may already be getting reports like this. We report it depending on the octants, being anterior to the right, posterior to the left, right to the top, and the patient usually is laying down for this type of procedure, left lateral. So the takeaway message really, that in our doorstep, in the eastern suburbs and in just the lower North Shore and some of the Shire suburbs, have got an increased percentage or rate of patients with anal cancer. The majority of them live in these areas in Sydney, and the percentage of HPV related in comparison to other parts in Australia, you can see that it's only 8 out of 100,000 population, whereas there's about 40 in males, in all males. So that basically will mean that if 25% of men will be, gay in these areas, which, it could be, it's about 160. So it's about triple that. So think of that risk population: HIV positive men and women with past vulval vaginal cancers, immunosuppression, solid organ transplant, and inflammatory bowel disease. The screening guidelines, keep an eye on them because it will change very soon. The treatment of the precancerous lesions, and if this is going to stop anal cancer from progressing, these results will come soon at the end of next year. And it's all very exciting. So that's my presentation for tonight. You ever need me, that's my mobile number.
Do you have any further comments?
Well, I just want to say that even as a colorectal surgeon, having done general surgery and colorectal surgery, this procedure is not something that we get taught or exposed during our training. And the only reason why I got exposed to this and got trained is because I always had the question of why are we not doing anything with anal cancer? And there is so much more out there than we know. And I was quite amazed of the incidence of females that, HIV negative. And I think it's important to take care of our, female patients that have a positive, pap smear and that has some non-specific symptoms in the anal canal. I think it's important for education, and it's also important for early detection. And I think that getting this education to you as a primary health givers is very important.
Okay, we have a few questions coming in. Is there any risk of anal cancer for women with genital warts?
So genital warts are the most benign type of HPV-related lesions. And no, warts in the research that we have that has been done, there is no relation to anal cancer. In fact, the people that develop anal cancers, the majority don't have history of warts.
Okay, the next question. Should anal screening be as routine as cervical HPV screening, for example, in men?
Well, in men, in gay men, HIV positive, we perform at St. Vincent's after having done the SPANC big trial that it was done there. After that, a risk stratification was done. So these men and other men in the same circumstances have been asked. So what they do is if they have a lesion, they're seen every 6 months. If they have a lesion that is treated and regressed or treated and disappeared, then they are seen every year. There is no clear guidelines because basically there's no guidelines, and this is all based on the data that they have been able to accrue over the years. So in my opinion, if you're asking me, in my opinion, I think the high risk people should have it once a year until we know what type of HPV is driving the actual infection. And if it is a high risk one, then they're put into a bunch where they need to be seen every year. And if they're in a non-high risk, then sometimes they can just be completely discharged. Well, just keep an eye on this because things might change very soon.
Okay, the next question, what does DARE stand for? And this person would like to say thank you for an excellent presentation and awareness of anal cancer.
Thank you. So DARE is a direct anal rectal examination, which basically means introducing an internal PR examination. So as colorectal surgeons, we call PR just the outside, just to look at the perineum and look around the anal verge. And then once we put our finger in, we call it DARE. Sorry, I shouldn't have abbreviated it.
Thank you. The next question is, what is the role of self-collection in anal swab for HPV as a routine screening tool? And if so, how often we are taking rectal swabs for prep 4 times a year? Can you guess what best practice will be in an asymptomatic gay man?
Yes. So from the comment from the attendee. I'm pretty sure that they have experience with patients, or they see these patients regularly, because there is actually a current trial called the TCAT, which is actually evaluating this, the comparison between a anal pap smear done by the patient, which are all gay men MSM, versus patients that are done at the clinic. And so far, there is no final results just yet, but so far, TCAT, or the self-administered by the patient, is showing that is the same, as effective and efficient in getting an appropriate sampling. And then the second part of the question was how often we're taking rectal swab for PrEP 4 times a year. Can you guess what best practice will be asymptomatic gay man? When you mean, can I just ask the poster, do you mean PrEP for before, for medication point of view? Like, does it mean the HIV related PrEP? Whilst he or she answers, 4 times a year, a rectal swab, I don't think is necessary. It all depends on the type of HPV that they had on the first anal PrEP swab. So if it's an HPV 16 or 18, they are in the high risk. They get the first HRA, and if that HRA, there is no symptoms and there is no lesions, there is no need to do it 4 times a year. You just do it. You come back in a year's time, you check again, and then if men are still asymptomatic at the second stage, the HPV is being cleared on the genotyping. I have seen that these patients actually get discharged.
That's it. Thank you very much for presenting tonight. And I think we will go on with our next presentation. So thank you again. We're now going to have Professor Stephen Riordan. He is a gastroenterologist and hepatologist, and will be speaking on the microbiome and the pathogenesis of chronic liver disease, inflammatory bowel disease, and neoplasia.
So good evening, everybody. I'm going to round out the evening by talking on a potentially enormous subject, but you'll be pleased to know that I'll focus it on 3 areas that I hope you'll find interesting. That's chronic liver disease, inflammatory bowel disease, and the role of the gut microbiome in neoplasia as well. And I've chosen those 3 areas because there is a story to be told, and our group's had an interest in all these 3 areas and has made a few contributions along the way. So I can address the topic with a little bit of perspective in those areas. So the first thing is to talk about nomenclature, because the literature can be very confusing. But the taxonomy of the microbiome is the phylum, the genus, species, and strain. So a genus is a family of the phylum, species is a family of a genus, and strains are a family of the species. If we look at the distribution of bacteria from the stomach through to the large bowel, we find there's a gradient. The stomach is relatively sterile. The small intestine has a higher concentration of bacteria, and the colon contains billions of bacteria. And they play a very important role in maintaining the nutrition of the colonocytes. So most of the energy required to sustain the integrity of the bowel comes from metabolism from the gut flora. So increasing numbers in the colon compared to more proximally, but more than that, there's a gradient in type of bacteria as well. The proximal gastrointestinal tract is colonized mostly by gram-positive aerobes, and the distal gastrointestinal tract by gram-negative anaerobes. An important point to make is that the majority of the gut microbiome just can't be cultured by standard microbiological methods. And it's because of this fact that various molecular technologies such as high throughput ribosomal RNA and whole genome sequencing has been so important in revolutionising microbiome research. And this has been over the past 10 years or so. In addition, assessments of functional activity have provided even more insight into the importance of the gut microbiome. So function can be assessed by metatranscriptomics, that's looking at gene expression profiles, metaproteomics, and metabolomics. Compared to looking at standard microbiology, where we can give you the number of bacteria per mil of secretion, microbiome sequencing studies usually rely on proportions of what's called compositional data. And so results are described as relative abundances and diversity of taxa or genes rather than absolute quantitation. It's just important to have that perspective when you read about the topic, because otherwise it can become very confusing. It's just as important to say what we don't know at present compared to what is known. What we do know of the human microbiome, most of which resides in the intestinal tract, is that there are 25 phyla described, over 2,000 bacterial genera, over 5,000 different species, and over 300 million genes. So the gut microbiome is more expansive than our own microbiome. About 80% of the genome maps to what's currently known, but 20% of sequences just don't match any known microbial genome. And when we look at function, about 40% of genes don't match to a functional database. So everything that's written and discussed at the moment in terms of the microbiome has to be considered in the context that there's stuff we don't know. And more than that, we don't know what we don't know. It's a bit like Donald Rumsfeld's famous quote from years ago, where there are known unknowns and unknown unknowns. And it's true with regard to this. What we can say, though, based on available information, is that at least in an individual, the gut microbiome is remarkably stable over time. Now, this is in the absence of interventions, use of antibiotics, drugs, etc., that we'll come to in a minute, but both in terms of the taxonomy and the functional composition, the gut microbiome in a particular person is resilient. And in fact, intra-individual genus and species level compositional variation over time is substantially lower than differences between people. But there are major differences between people. And there are major differences in apparently healthy people. So large inter-individual variability. In fact, only a minority of gut microbes are shared across the majority of individuals. If we looked at a European data set of over 3,000 samples, only 17 bacteria were actually identified as a component of the gut microbiome in more than 95% of people. And of 639 bacterial species in a population study of over 1,000 Dutch individuals, 73% were present in fewer than 10 individuals. So there are lots of possibilities and lots of variations in groups of people that for all intents and purposes are perfectly healthy. But what we can say is that diversity of the microbiome is important. In general terms, the more genes, the more genera, the more species, the healthier we are. And it's a lack of diversity that's more associated with disease. And that word associated is important. I'll come to that in a minute. More than that, it's less a response to a particular perturbation, but rather post-perturbation resilience. That's the hallmark of gut microbial health. I guess in general terms, it's not how many times you get knocked down, it's how many times you get back up. That's important. And the same applies here. So using the word association is important in couching any comments that we tend to make in terms of the gut microbiome, because association shouldn't and doesn't imply causality, especially in this topic where there's a bidirectional interplay between the gut microbiome and disease, insofar as various disease processes are known to affect the gut flora. And so the question is, what's chicken and what's egg? Is it a change in gut flora causing disease? Is it disease causing a change in gut flora? Or is it a bit of both leading to a reverberating cycle? Having said all that, factors potentially influencing the gut microbiome have been described, and they're best thought of as microbiome intrinsic, so driven by the microbiome, host intrinsic factors, host extrinsic factors, and a whole range of environmental factors. This is shown schematically here. This is not our own work. This comes from a group from Germany reported in Cell a couple of years ago, but it's a useful way to think about things. And if we look at all the possible things that have been found to potentially influence the gut flora in an individual person, you'll find there are host factors, there are microbiome factors, there are things outside the host's control, and there are environmental factors. So there's literature on all of these things, and they're all potentially important in the right circumstance. And that's all a bit daunting when you look at that. But a key finding is that even the strongest of these co-varying factors explain only a surprisingly small fraction of inter-individual variation. So yours and mine are be influenced by these factors to some extent, but the estimated combined effect size in dictating the difference between yours and mine of all these factors taken together is only 10 to 15%. What that tells us is that there's much, much, much more to learn about the interactions of all these factors and the gut microbiome. Let's look at a couple though, because host genetics, medications, diet, and age are all things that are potentially relevant clinically. So let's just spend a minute or two looking at what's known and what's unknown about these things. With regard to host genetics, it's clear that the gut microbiome is both intricately and reciprocally linked to both innate and adaptive immune systems. There are 42 polymorphisms of innate and adaptive immunity genes that have been identified as important. But when you add up those 42, it accounts for only around 2% of current gut microbiome compositional variation. So genetics is important because 2% is still a substantial number when you look at the number of genes here involved. So 2% influence is still a relevant thing to think about. But only 42 nucleotide polymorphisms so far have been described. There are potentially many, many more of these. Medications, many have been implicated. We all talk about antibiotics and the effect of antibiotics on the gut flora and the impact on post-antibiotic irritable bowel syndrome, for example. But there are many drugs that have been implicated in changing the gut flora. In fact, a recent large-scale in vitro study that tested over 1,200 marketed, all-human targeted drugs found that about a quarter of them, that's an enormous number of drugs, inhibited the growth of at least one gut commensal. The most commonly implicated are not just antibiotics, but proton pump inhibitors. These are important. Arthur touched upon the effect of reduced stomach acidity on iron absorption. Here the issue is reduced stomach acidity promoting overgrowth of bacteria in the stomach and small bowel in particular. So swallowed salivary flora is no longer killed by gastric acidity, and so the bacteria survive and grow and then have metabolic effects. In addition, of course, if somebody's taking a proton pump inhibitor and gets exposed to Campylobacter or Salmonella, then those strains are more likely to survive because there's no gastric acidity as one of the first lines of defense. So antibiotics, proton pump inhibitors, but others as well, statins, metformin, beta blockers, ACE inhibitors, selective serotonin reuptake inhibitors. The list goes on. And all of these drugs have effects on the gut flora. And once you disturb the microecology of the bowel, then there are flow-on effects that affect a whole range of not just bacterial strains and genera, but functions as well. Diet is spoken about a lot in terms of influencing the microbiome, but believe it or not, relatively little is proven. Radical switches in diet, say from an all-plant or an all-animal-based diet to the other, demonstrate changes in specific groups of microbial taxa that are consistent and predictable across individuals. But most people don't go from an all-plant or an all-animal diet. It's not as radical as that. In general, most reported studies so far have investigated very broadly defined dietary shifts, such as overall levels of protein and carbohydrates. And there are differences related to this. But the potential effects of more defined, more specific nutrient interventions, and this is something that we, of course, would aim for clinically rather than a broad-based scattergun approach, are only now beginning to be explored. This is an area that will expand enormously in the next couple of years. In general, elderly people show a lack of diversity of their gut flora, and as we mentioned before, that tends to be bad. They show a decreased stability of the gut microbiome as opposed to the general rule, and they display compositional shifts. A particular genus will overgrow others, vice versa. It's no longer stable. And this is presumably influenced not just by aging itself, but by general health factors and by confounders such as diet, housing, environment, other environmental factors, physical exercise, which we know can have an effect, and the many medication effects that have already been reported. One of the important things that happens with aging is bacterial overgrowth, both in the stomach and the small intestine. This is a concept that was identified by us in the late 1990s, where we looked at a whole group of people of varying ages and looked at the incidence of bacterial overgrowth and the nature of the overgrowth flora. And we found that in people over 75 years or older, then bacterial overgrowth of the small intestine was extraordinarily common. It used to be thought that this was an entity that only occurred in patients with duodenal diverticular, gastric acidity issues, so pernicious anemia, etc. But this is extremely common, and the mechanism is due to small intestinal dysmotility as we get older. It's very common. So with that as a background, what about the gut microbiome and the pathogenesis of liver disease? We know that small intestinal bacterial overgrowth is common in liver disease. We know that there are general shifts in fecal flora related to liver disease, and many factors play a role here. An important one is cholestasis, because bile acids influence the growth of so many different bacteria, and this becomes disturbed in patients with chronic liver disorders. And given that we'd already found that small intestinal overgrowth is common, the important next question was, is liver damage in small intestinal bacterial overgrowth an issue? We know it potentially could be based on animal models, but there was a dearth of literature in people. So this was the very first report of liver damage complicating small intestinal bacterial overgrowth. And as we've just seen, this can happen in a whole range of people, but as we get older, then bacterial overgrowth is more likely to occur. As people get older, then liver disease tends to become more prevalent, depending on mechanism, of course. And so it's a very important question. What we found in this first report is that bacterial overgrowth of the small intestine is not a major risk factor for liver damage in humans, but it can and does occur when the overgrowth flora includes gram-negative obligate anaerobes. And it's overgrowth with gram-negative obligate anaerobes that tends to complicate the course of liver disease. With that in mind then, an important next question was whether we could manipulate the gut flora in people with chronic liver disease for therapeutic benefit. In terms of manipulation, people talk of probiotics. We always talk of probiotics can do this and do that. There's not a lot of literature for a lot of things that probiotics are meant to do, but there is literature in some circumstances, in some clinical scenarios. Symbiotics, not SYM, but symbiotics, are a combination of probiotic and fermentable fibre. You might wonder, well, why do we need the fibre? The rationale here is that the fibre gets metabolised by the gut flora, all the gut flora, usually the short-chain fatty acids. The short-chain fatty acids will be toxic to many bacterial strains, especially toxic ones. But probiotics tend to be members of lactic acid bacterial families. So they're relatively resistant to the effect of short-chain fatty acids. So if we combine a probiotic with fermentable fibre, this is a strategy by which probiotics will selectively survive and the pathogenic bacteria won't. It just improves their ability to colonise. So we looked at the effects of symbiotic modulation on patients with liver cirrhosis who are encephalopathic. So they've got impaired liver function and hepatic encephalopathy complicating that. And this particular paper was published in Hepatology, and there was an accompanying editorial which made the comment that the concept of doing this was something that we touted some years before, and we used a combination of probiotics, the 4 of them shown there, all members of the lactic acid bacterial families, combined with a bioactive fermentable fibre. We happen to use beta-glucan, inulin, pectin and resistant starch. They're all available. And so we put these in sachets and we gave them with our sachets of probiotics. Just as an aside, psyllium, metamucil, all these things that are often available from a chemist's shelf are non-fermentable fibre, so aren't useful at all in this regard. So our active study group got probiotics and fermentable fibre, so that's called a symbiotic group. The second group just got the fibre, fermentable fibre, and a third group got non-fermentable fibre as a placebo. And this is interesting because what we found was that in patients with cirrhosis, if we look at lactobacillus levels in healthy controls compared to cirrhotic patients, then there's no difference between the two in terms of fecal composition. And lactobacillus aren't harmful. In fact, they're probiotic, if anything. On the other hand, E. coli and staphylococcal species are potentially pathogenic. And if you look at the levels of E. coli in healthy controls, so 7.3 is the number, and you look at the cirrhotic patients here with before supplementation, then there's a difference between the two. Healthy controls, much less, but cirrhotic patients, more pathogenic bacteria, more pathogenic E. coli. Similarly, more pathogenic streptococcal species as well. When group A, the symbiotic group, was given the various cocktails, then after 30 days of supplementation, lactobacillus counts go up and stayed up over the course of 2 weeks of monitoring. And E. coli and staph species both reduced. And this happened with symbiotics, and with regard to E. coli, just fermentable fibre alone. What's happening here is that the gut flora is metabolising the fibre to acids, and the acids are killing the E. coli. But what this shows is that in cirrhosis, the gut flora, particular marker organisms, there are so many unknowns with the gut microbiome, but if we select a few marker organisms, if you like, of good guys and bad guys, we find that we can supplement the levels of good guys and we can reduce the numbers of potentially bad guys. More than that, we could reverse hepatic encephalopathy in 50% of patients with symbiotics, but we could also reverse encephalopathy with fermentable fibre alone. If we looked at factors important in resolution of encephalopathy, then it was the intervention with symbiotics or fermentable fibre that made the difference, not the type of cirrhosis or the age of the patient. But interestingly, and for the very first time, we found that not only did encephalopathy improve because we're reducing or changing the bowel flora, hence reducing ammonia production. Ammonia is important in encephalopathy. But encephalopathy improved in addition because we actually managed to improve intrinsic liver function. And we use the POWPH class to score this in clinical practice. So liver function can be improved by modifying the gut flora. And it improves by reducing necroinflammatory activity and all the individual functional parameters that make up the child class. The bilirubin level, the albumin level, and the prothrombin activity all improve. And they improve with symbiotics and fermentable fibre. So there are things that can be done clinically to improve liver function in people with established cirrhosis. We then looked at why this was happening. And in this study, we looked at clearance of indocyanine green. Indocyanine green is an inert dye that's injected intravenously. It's taken up by the liver. So it's carried by hepatic blood to liver cells. It's cleared by liver cells, unchanged down the bile duct and excreted. So clearance of indocyanine green, or the converse, retention of indocyanine green, and this is how we generally report the result, the retention rate at 15 minutes, is an overall influence of global liver function, hepatic perfusion, functioning liver cell mass, and biliary excretion. And what we found is that we could improve overall liver function with symbiotic treatments in cirrhotic patients. The benefit was a specific concept in cirrhosis because it didn't happen in chronic hepatitis where liver function was already good to start with. We couldn't make it better. And we found that the improvement was the consequence of changes in pro-inflammatory cytokine levels, and in particular related to interleukin-6. Interleukin-6 is a pleiotropic cytokine, and its importance here is in driving priming liver cells for regeneration. So symbiotic treatment can improve the key marker that primes liver cell regeneration and can lead to improvement in liver function. And this is the very first description that this can occur and the mechanism by which it does occur. And since then, there's been other studies looking at the effect of different probiotic formulations and different strategies to affect gut flora in liver disease that have found consistent results. Moving on to inflammatory bowel disease, studies into factors responsible for the inflammation in IBD have shown that there's a disturbance in the otherwise symbiotic. So this is not symbiotic that we've used in terms of gut flora manipulation. This is symbiosis. The normal symbiosis between the gut flora and the local immune system is disturbed. The normal tolerance is lost in inflammatory bowel disease. There are genetic factors at play, there are environmental influences at play, and almost certainly there is dysbiosis of the gut microbiome at play as well. We know that there's a reduction in diversity of fecal bacteria in IBD. In Crohn's disease, there's a reduced number of bacteria with anti-inflammatory properties, such as the ones listed here, Faecalibacterium and Bifidobacterium species. And there's an increased number of pro-inflammatory species, such as E. coli. And there are other changes in ulcerative colitis. They're different, but there's definite changes. There's an underrepresentation of anti-inflammatory lactobacillus and Akkermansia species. The question, of course, is how important that is. Because if you remember our big wagon wheel slide from early on that showed all the factors that might potentially interfere with commensal gut flora, inflammation was one of them. And it's definitely true that the composition of the commensal gut microbiota can be disturbed by inflammation. So an important issue, and one for which there's little data currently available, is whether the dysbiosis so far identified in established IBD is present at disease onset and hence might play a role in initiation of the disorder, or rather develops as a consequence. We can't say too much about this at the moment, but we can quote a study in paediatric patients where a significant reduction in bacterial diversity was demonstrated very early in the course, suggesting that it might be a primary event. But nothing has been found so far along those lines with ulcerative colitis. The data is very preliminary. We don't really know. One thing we are coming to realise, though, is that a particular member of the commensal flora might be very important in the pathogenesis of inflammatory bowel disease, and this is Campylobacter concisus. This is a distant cousin of Helicobacter pylori. It's a commensal bacterium that's mostly found in the oral cavity. It's found in increased proportion in patients with inflammatory bowel disease compared to healthy controls in both the small bowel and large bowel. And more than that, the inflammatory response that we see in inflammatory bowel disease can be tied back to what Campylobacter concisus does in vitro. And a lot of work is currently going on to further define this. But this was a first description of Campylobacter concisus from one of our groups at the uni here back in 2016. And since then, there's been a plethora of publications, all finding similar things and all pointing to a particular effect of this particular strain. There are many more. But the important is that it identifies a paradigm by which we can work off in future. If we can't interfere with Campylobacter concisus and no doubt other potential candidates in the future, what we can do is crowd out those potentially harmful effects by use of probiotics. And there have been a number of studies now reported in a study in 2020 from the World Journal of Meta-Analysis, not our own work, that looked at different probiotic strains and their effects on patients with inflammatory bowel disease. It doesn't matter whether the dysbiosis was an initial effect or a subsequent effect. The question is, if you reverse that dysbiosis, can you lead to clinical improvement? And the answer tends to be yes, if we look at these studies. And there's quite a few now studies here that all demonstrate the same thing, both in ulcerative colitis and Crohn's disease. It does seem to depend to some extent on which cocktail of probiotics are used, and these are the ones that show a positive effect, at least as we speak. The third clinical picture I wanted to talk about briefly, just as we finish off, is the effect of the gut microbiome on colorectal cancer. We know that the gut microbiome is enriched in some bacterial species, Fusobacterium, Peptostreptococcus, and Bacteroides. On the other hand, it's consistently been shown to be depleted in Streptococcus thermophilus. The question then is, how functionally important are these changes? How important is this dysbiosis in the pathogenesis of colorectal cancer? And does it lead to any therapeutic potential? In the past few weeks, an important study has been reported looking at Streptococcus thermophilus in a mouse model of colorectal tumorigenesis, both carcinogen-driven and genetically predisposed mice. And what this study found quite conclusively is that Streptococcus thermophilus could suppress intestinal tumorigenesis in the mice. The effect was mediated at least in part by secretion of beta-galactosidase, so there's a mechanistic explanation for the effect. And it opens the door for, although clinical studies are needed and no doubt will follow pretty quickly, this probiotic could represent a potential prophylactic for preventing colorectal cancer in humans otherwise predisposed with minimal side effects. And if you look at different probiotics that are available from the chemist shelves, you'll find Streptococcus thermophilus is a component of at least some of them. Very, very, very little is known about the microbiome of the esophagus. And in fact, the most comprehensive assessment of the esophageal microbiome was reported by one of one of our groups in 2018. And what we found in that study, and what's the subject of ongoing research, is that there seems to be a link between a disturbance in the esophageal microbiome and the pathways that lead to the development of esophageal adenocarcinoma. And more than that, there seems to be a spectrum, a pathway of disease that goes from normal through glandular metaplasia, through Barrett's esophagus to esophageal adenocarcinoma. It may be that the driving effect leading from Barrett's esophagus to esophageal cancer is not reflux itself. It's a change in the microbiome, partly driven by reflux, but the complicating change in the microbiome that actually is the final step that decides who will and who won't develop esophageal adenocarcinoma. Much more work is being done about this at the moment, and more will follow. So in summary then, this is my first slide, and this is a summary of what we've discussed, just to encapsulate the concepts. So in chronic liver disease, there's evidence of dysbiosis. We know that symbiotics are associated with a change in the fecal flora, as is supplementation with fermentable fibre. And we know that both symbiotics and fermentable fibre use can be associated with improvement in liver function in patients with established cirrhosis. The asterisks point out where our group has made some sort of contribution to the field. With inflammatory bowel disease, similarly, there's evidence of dysbiosis. There's a potential pathogenic role for Campylobacter concisus. Probiotics are associated with improvement in inflammation of the bowel in this circumstance. And in neoplasia, with regard to colorectal adenocarcinoma, there is evidence of dysbiosis. It may be that a particular probiotic that's deficient in patients with bowel cancer can lead to a beneficial effect. This has been clearly shown in animal models. We're waiting for human experience. And in esophageal adenocarcinoma development, there's evidence of dysbiosis, and the full importance of this will also be defined in years to come. But as I say, it may be that esophageal adenocarcinoma is to do with the esophageal microbiome and not due to other factors. So I thank you very much for your attendance, and I'm happy to answer any questions if there are any.
Thank you very much, Professor Riordan. We don't have any questions at the moment. If everyone would like to just quickly put a question in before we run out of time, I can give you a few more moments. While we're waiting, was there anything else you wanted to add?
No, Susan, I'm happy to leave it at that.
Okay, thank you very much. We'll just wait another moment in case there are any questions. Here we go. What about esophageal microbiome and EOE?
We don't know is the bottom line. Presumably it's very important because not all patients with eosinophilic esophagitis will have a demonstrable allergic predisposition when they're assessed in our various allergy clinics around Sydney. The hallmark of eosinophilic esophagitis is an interleukin-5 response. And we know that some commensal bacteria, loss of tolerance to some commensal bacteria, can lead to upregulation of interleukin-5 type pathways. But there's no work on this at the moment. There's very little work on the esophageal microbiome in particular, in general. It's been a very understudied field, but no doubt this will change as the entire concept of the microbiome continues to explode.
Fecal transplant?
Fecal transplant has a role in patients with, well, first of all, it's quite a crude approach, I must say. It has a role in patients with recurrent or refractory Clostridium difficile-related colitis. Our first-line algorithms there have to do with metronidazole, vancomycin. Fidaxomicin is a very useful drug. It's the only drug for Clostridium that's actually bactericidal. The other two, metronidazole and vancomycin are bacteriostatic. So fidaxomicin is an underutilized antimicrobial approach. If that doesn't prove to be effective, then fecal transplant is an option. It's been proposed in a whole range of other different contexts where the literature is quite vexed. I will say that there have been adverse outcomes, especially in immune-suppressed patients. There was a death in the United States not that long ago in a transplant patient who was given a bone marrow transplant, given a fecal transplant. So in the right circumstance, has a role, probably not a proven role in all the things that's currently touted to be useful for. Time will tell.
And the next question is actually a comment saying thank you. So I'd like to thank you as well. I think we will end that there. And we have our next speaker is Anna McGlynn from Health Pathways. She's just going to give us a quick update. Thank you again, Professor Riordan.
You're very welcome, Susan.
Thank you, Anna.
Share my screen. So hi everyone, I'm from Health Pathways South East Sydney. I'm just here to remind you that Health Pathways is there to support you for your local clinical and referral information around gut health, but also in any other clinical areas. So we've got a QR code here. If any of you haven't looked at Health Pathways, please get on and have a look. This is our mobile friendly site and the username and password can be shared with any healthcare workers. We've got quite a few pathways around gut health. That's a bit of a list. There's definitely more in process at the moment. We're also working on IBD, IBS and celiac disease. If you are referring patients into the Sydney area, there's also Sydney Health Pathways. They also have a lot of pathways in general as well as in gut health. We also now are sharing username and password. So if you've used Sydney in the past, you can use that username and password for the South East Sydney site as well. And these are a few of their gut health pathways that might be relevant for you after listening in today. And this is the team's contact details, both for South East Sydney and Sydney. Please get in touch if you have any questions or feedback for the teams, or if you haven't used it before and you want a hand navigating the site. There's also an ability on the bottom of each pathway to use this little blue icon if you have any feedback at any time, and we regularly review the pathways at least every 3 years to make sure they're up to date. And that's it from me. Thank you.
Thanks, Anna. Thank everyone for attending tonight. And I'd like to thank our speakers once again for taking the time to present. And thank you all for attending again. Please complete the evaluation survey that will shortly pop up on your screen after I close the meeting. Please note, if you are viewing the webinar on your smartphone, you may not receive the survey. You will, however, receive an email tomorrow, which will include the link to the evaluation survey. Please visit our website to register for more upcoming webinars, including our next Prince of Wales private event, Men's Health, on Wednesday, the 2nd of June, and the Responding to COVID-19 Vaccine Uptake and Hesitancy on the Front Line on the 12th of May. Have a good evening. Thank you again, everyone.
Thank you.